So, good evening, everyone. My welcome to all of you, all speakers, delegates. Welcome, Dr. Jailal sir, our National President of Indian Medical Association, Honorary Secretary General Dr. Jayesh Lele, Dr. Vinay Agarwal sir, and special welcome to Mrs. Navika Kumar. Thank you so much for accepting to be with us today. Our today's day in charge, Dr. Narmada, will start off the program. Dr. Narmada, over to you.
Thank you, Dr. Erika. I really thank the National Headquarters, Dr. Jailal sir, Dr. Jayashli sir, and all the seniors who have given me the chance to moderate along with Dr. Erika for this program of Safe Motherhood. Being a pediatrician, I'm highly privileged to work with obstetricians and pediatricians where we need to have a very close contact for the safe motherhood and the safe delivery of the babies. So we know that whatever happens in the antenatal period has got a significant impact on how we are going to deal with children. And today, my entire crux is about the journey continues. Yes, the journey continues for the mother, the postpartum journey, which is very, very significant for her. This is first initial we always say the logicians are the luckiest because they get to give the good news, whereas we pediatricians have to tackle with so much of the doubts. So the journey is in fact very significant now because she's not only worried about herself, she's so much worried about the baby, and she's got to think for two people. So we have to deal with her very carefully, and there are a lot of issues with that. And behind this, that is why we had kept on the postnatal blues, though it is not a very significant topic. Now with the post-COVID, there are psychological effects that is coming up a lot for the mothers, and that is the reason we wanted to cover that. We also want the mothers to get back both to a natural self immediately, both in her health as well as on her femininity and sexuality, because it's so important to maintain her health in the postpartum, and that is where most of the mothers leave it off. And the third, we have a very interesting topic of continuing of the antenatal blues going into the postnatal period. We have excellent speakers and chairpersons who are going to moderate that. But before that, we have a women of eminence today. Wheel the thunderbolt of Athena, guide our hand to pen new anthem, be the lungs for a forgotten dream. This was a line today I had read in the newspaper, and this is so very true for our guest speaker today. The voice of the female, a voice for the just. Her stand is let truth prevail. You can't intimidate us at times now and can't take away what is true. This is Navika Nair, ma'am, for you. Navika Kumar for you. She is a group editor, Politics, Times Network. She's a very popular news anchor, a towering personality in political journalism. She has been heading the Times Group as group editor of politics. With more than 3 decades of investigative journalism and political reportage, she brings out the best of Indian political spectrum in her much watched and followed show in News Hour in Times at 9 p.m. Since childhood, she was very much interested in business and economy related issues, and she took up her post-graduation in the Gokhale Institute of Politics and Economics, Pune. Coming from a very prestigious family, she had 2 careers before her. One, the banking career, which her father was already there, and the other was to take on this investigative journalism. And she took on the investigative journalism, joined into Economic Times, and now, since August 2005, she started her career in Times Group, now become the group editor of politics. She's very well known for her reporting on Commonwealth Games and Lalit Modi IPL scam, and her Twitters are so famous, she sticks to her point and makes sure her truth prevails there. The true words, thunderbolt of Athena, Mrs. Navika Kumar, for you. Ma'am, the stage is yours.
Thank you so much. And what can I say to all these people here? Doctors, you are our pride. And the way I look at it, well, we are nothing. It is because of you that we are here. It is because of you that our children are here. And it is because of you that we can actually, be proud of being alive and having a family. I especially have a big word of thank you that I need to say to the doctors who attended to me, both pediatricians and my gynecologist, because I have two kids and my pregnancies, both pregnancies were extremely tough, and they were 10 years apart. So in the first time, it was so difficult that I was carrying a very big baby. I couldn't breathe because instead of the baby settling down, it was growing with its head a little up, and therefore my diaphragm, lungs were being compressed, so I couldn't breathe. And when I tell this, as something of my sharing of my experience with people I work with, they say that maybe I'm taking my revenge now from the world because I don't let anybody else breathe when they come on my show. Well, it's not revenge, but it's just that from such close quarters to have seen how to deliver a child and how to go through that entire process. I don't know. Sometimes the number of children that India produces still is mind-boggling to me, because for my two kids, I had major problems. First kid, I told you. Second kid, in the 7th month, I had hypertension and I was rushed to the hospital, and I had my baby in the 31st week. And the baby was in the neonatal ICU for 3.5 weeks. For me, the biggest trauma was that I had the baby. Both my babies were cesarean. I had my babies in 5 days. I was sent home the second time around, and the baby was kept back in the neonatal ICU. And that to me was the biggest challenge as a mother I had to face. Firstly, nobody would ever tell you. My child was, I think, 1.3 kgs or something. And look at my size. Nobody would ever believe that I would have such a small baby. But because it was a premature baby, it was a very, very challenging period for me. And it was, I don't know what came into me despite that very, very tough period. You have all sorts of hormonal changes going on in your body. You've just been operated, and 20 years ago, cesarean operations were considered as major operations. So it was a very, very harrowing time, and I remember I have spent hours speaking to my little baby son in the incubator, and I used to keep having this conversation with him that, come on, you are my son, you are a fighter, we are fighters, we'll come out of this. I don't know if it helps. I don't know if there is any science that can actually prove how this happens psychologically. But I know that I just tried this, and I spoke to my child through the incubator glass, kept speaking to him, kept telling him that, come on, we have to survive, we have to survive. And normally people say that it takes 6 to 8 weeks for the child to be released. And they must cross that 2 kilo weight mark. But I still remember that, and his digestive system hadn't really developed. So if I would feed him also, he would have ulcers on his digestive tract, so I couldn't feed him. And to see your child with such a small baby with both hands, they were intravenous things, both ankles also there was, and there was this little child, and there was light because there was jaundice also. So it was a very, very precarious, very scary time for me. But uh, I don't know if it helped, but I believe for myself that speaking and whether he heard me or not, but just speaking and bringing that fighting spirit that I had within me, that I have to take my child home. And the doctors would never say whether he's out of danger or whether he would survive or not. But I used to keep telling him that I'm not listening to the doctors. You and I have to fight this together, and we will fight this together. And in 3.5 weeks, I did take him home. But the first 6 months were very difficult because nobody would be in a position to pick up the child because he was so small. And normally I was used to giving my older son, a bottle of milk to feed him. Here I was giving 2 milliliters through a dropper, and I had to feed him every 20 minutes or 25 minutes. So I don't think 6 months I ever slept at night. I just sat on a comfortable chair which had a little armrest so that I could hold the baby and give him soya milk through the dropper. And that is how our first 6 months went. Today he's 20 years old and he is in college, but I still haven't forgotten. It's almost like yesterday that I had this kind of a challenge in my life. uh, but I remember that it was nurses and doctors uh, to whom I owe the lives of my children and my own life, because my friends used to later on tease me that I'm such a dramatic person, just like a Hindi film. When I was taken to the hospital, the doctors told my husband, either mother will survive or the child will survive. We can't promise you both. So it was almost like a Hindi film, and we today can laugh about those days, but it was actually uh, the unstinting work that was put in by the doctors, by the pediatricians, and the nurses, round the clock. And we owe my children's life to your fraternity. And that's why I always say salute to you, because the kind of humankind, human service that you do, I don't think we ever do. So I don't know. I'm recounting these experiences because I just want to bring to your notice perhaps challenges that mothers face when they are in situations like this. Uh, in a sense, there was nobody to guide me or hold my hand through this period 20 years ago. Maybe um, in the current days, counseling is extremely important, if somebody goes through. So I just feel that somewhere you should just make that mandatory for young mothers, because otherwise we're just groping in the dark. And I don't think Google search was very helpful in those days as it is today, because whatever questions we feel are too dumb to ask anybody, we normally, every lay person just Googles them. So and I don't know how much of correct advice comes through that, but counseling, especially in tough pregnancies and tough deliveries, is something that must be a part of the entire childbirth regimen. I just feel that uh, whether you had one kid or two, I don't think anyone is ever completely ready to deal with the many facets of emotions and challenges that come with motherhood. So that is something that I have always felt should be upheld and recommended to all young mothers. And since then, I don't think there is anything called safe motherhood. It's trial and error through which we learn parenting, through which we learn becoming friends of our children. Everybody has a new formula. There is no one size fits all. I really wonder how you people as doctors deal with so many different kinds of cases that come and find solutions for each one of them, and actually become the guardian angels, helping families, helping mothers and fathers and children as well. I really think that yours is the noblest profession. We do our bit as the fourth pillar of the democracy, but we get a lot of what do you call face time, stage time to make the noise that we do. Your tribe is the silent one, which works behind the scenes, but actually, we all owe our lives to all of you doctors. So, very, very grateful to each one of you. And thank you so much for having me here on this platform. I don't know, if any of you will appreciate the Hindi, I want to say, but दिए को रोशनी कैसे कोई दिखा सकता है? You are the guiding lights. We can't show you light. Our life depends on you, and there are many facets that come with becoming a mother. It's a new challenge every phase that our children go through, and yes, from the initial period when we used to visit our pediatricians virtually every month for some inoculation or the other, to then when it slows down a bit. Initially, you don't even know how to deal with the congestion in your chest, your child's chest. You don't know how to deal with it because every child reacts to it differently. My child would just keep throwing up everything, and the doctor would end up telling me, "It's good, the phlegm has come out." And I used to say, the child hasn't eaten anything. Whatever he's eating, he's throwing up, and the doctor is saying this is good because the phlegm is coming out. So, as a mother, I was always in a state of confusion on what is good and what is not good. Uh, so, so, uh, maybe, of course, these days things are so much more organized, and there are booklets that every nursing home or hospital gives you, when you give birth to a child. Uh, but in our times, one kid 20-year-old and one 29-year-old, things were slightly more, exploratory for us. Um, but but really, I do feel in both my deliveries, I've had, of course, the blessings of God, which is the major reason why life exists, according to me. Possibly the only reason why life exists. But the major reason were the doctors, the pediatricians, who came in and held our hand, literally, figuratively, and all of those doctors who were at the end of a telephone line, listening to our frantic calls at different times of the day and the night. My child is crying. Does he have colic? What should I do? My child is, with his eyeballs are turning up. My child's veins are showing on the cheek. I've made, I don't know how many such calls to my pediatrician to just check what should I do. And sometimes you feel that, are you a good mother at all or not? Because you don't understand why your child is crying in the beginning. And if you don't understand his language, then are you good mother at all or not? And this is especially for working women, this is the biggest issue we face on a daily basis. Am I a good mother or not? Am I looking after my child enough or not? So this goes on. It still goes on even when the children are, uh, you know up, and one is in college, one is got a career. Those challenges still remain. And of course, I can even share with get up at night and just touch him to see if he was breathing or not, because he was small. I didn't know, without being told how to breathe, whether he would forget how to breathe. What if he forgets? I used to ask my mother, what if he forgets breathing? He's so small, he's so tiny. Who will teach him how to breathe? So I would wake up suddenly, at night to see, is he breathing? इतना छोटा है, इसको कैसे पता चलेगा कि सांस लेना है every minute, so many times. And then, of course, when I had the premature baby, preemie as we used to call him, I used to feel he's so small. I don't know whether he'll be able to breathe or not. Are his lungs developed or not? So I'm saying the insecurities come from such basic questions in our mind. Um, but hats off to your.
Already in this tournament in the group phase.
I think somebody else wants to speak.
No, ma'am. Please continue.
So I was, I keep used to wonder, what is the best way to do this, and how do doctors come out with so much patience? They never lose patience, because if I'm asked the same question, for the fifth time, I'd probably scream and yell at somebody in front of me. But you people have so much patience, that there is so much to learn from your fraternity. That's all I have to say to you. A big thank you to each one of you who's here, who's not here, everybody who's a doctor, and to whom we owe our lives, our children's lives, our families' lives. When our parents are old, when our children are young, it's really doctors who take us through all of this. And we sometimes tend to take them so much for granted that we don't thank you people enough. So thank you so very much for having me, and thank you for just being who you are. Thank you.
Thank you so much, ma'am. That's such a nice words to hear, and it really gives us a morale boost in this very difficult times when IMA is really tackling with views and violence against doctors. We had earlier programs, and we had a stage demonstration also last week, and really your words of support really means a lot to us. And definitely it is so much apt because our program today is on postpartum mothers. So listening to, I have seen you in the TV, and to see such a brave person themselves having so much of doubt, then we can imagine how a very weak mother will be. And this program was exactly planned for 2-3 aspects. One is preventing. We don't want to have a preemie at all. We want to support them. Supporting them through the pregnancy so that they come through the hurdles, and then we are going to support them further. So this entire program was designed for this, and it was very apt that you discussed about those things so that we could see from the mother's point of view what it really means. And thank you so much for joining on this day along with us. It really means a lot, and this is our gratitude. This is our memento to you, memento only, but still it just shows that we are very thankful for you for having joined with us. So Erika, you want to add something, Dr. Jailal sir?
Thank you. Good. So just keep on going.
Thank you so much. Thank you so much. And to you too. Keep on going. These incidents, please put them behind you. For every 1 or 2 people who misbehave with you, there are 1 or 2 crores who are so proud of you. So just ignore these incidents. As Jesus would have said, they know not what they are doing. So forgive them, let them go. I think the man up there will take care of them. But all of us, from the bottoms of our heart, we thank you for all you have done for us through our lives. And of course, the challenging last 1.5 years, where I'm sure you've had no personal lives, just looking after Indians in different conditions who come to you has been so challenging. Salute you all.
Thank you. Thank you so much, ma'am. Thanks. Thanks a lot. And as you said, truth will prevail. You keep telling that, so truth will prevail.
Absolutely.
Yeah. Thank you. Thank you, ma'am.
Thank you.
Erika, shall I proceed with the session? Yeah. So I'm very happy to proceed with our postpartum care, where our journey continues of the CME2 as well as our program. So now we have our beloved chairpersons. I'm very proud to introduce our first chairperson, Dr. Chitra Tangvil, who is the chairperson of our Women's Doctor Wing in Tamil Nadu. She's an MBBS from Tanjavur Medical College and DGBO from Manipal. Very meticulous to the core. She's a very active person who has guided just really handheld me for the past 2 years, motivated so much of our women doctors wing. She has been very active in FOXY2 and IMA. She has won national awards for the best adolescent health education program. She has also Santanarayana Birudu in 2018, Mayan Award in 2018. She had been awarded for a distinguished service in medical community. Her list runs long, and she has presented papers also in the national level conferences. So this shows that how much a private practitioners can go and help into a community-oriented field. And she always keeps telling about community orientation, social education. This is her main motto. I'm very happy to have Dr. Chitra Tangvil here for moderating this session. Along with her, I have another illustrious person, Dr. Sampath Kumari ma'am, who is the chief and HOD of the Muthukumaran College, and she is the FOXY Vice President-elect of 2022. We have been very fortunate to have one president who be the, and then now we are having the Vice President-elect for 2022. She is also the chairperson of FOXY Adolescent Health Committee in 2016 and 18. She was a Deputy Director and Professor of OG in Institute of Obstetrics and Gynecology. She is a President Board of Studies in Tamil Nadu MGR Medical University, as well as she is a Governing Council member in ICOG from 2015 to 20. Various awards to her credit. The madam's best contribution has been into the adolescent healthcare, and me personally, I have seen her presentations that she has made for the adolescent program. It is like phenomenal. She's done a lot of community-oriented program for them, and I'm very happy that both illustrious OGians are there with us to moderate the session. Now I hand over the stage to them. Chitra ma'am.
Thank you, Narmada.
Yes, ma'am. Okay.
Good evening to everyone.
Yeah.
Thank you very much, Dr. Narmada, for your kind words. I thank Dr. Erika Patel for inviting me as a chairperson for this wonderful program. Today, we had Mrs. Navi Kumar with us. She is the daring, fearless woman, upright without any bias, and ruthless in attacking the wrong. But she is a very positive mother. She struggled with PIH and preterm delivery and delivered one big baby. She donated it very nicely. Thank you, our national IMA, for bringing such eminent personalities here. Today, 4th day of a week-long webinar series, Postpartum, the journey continues. Now, I am going to introduce our first speaker. Narmada, kindly share Madam's profile. Professor Sashwati Sanyal Chaudhary, MD, FICOG, FICMCH, FIAOG, Professor, Department of ONG, Gauhati Medical College, Chairperson, Medical Education Committee, 2013 to 15, Vice President, ISOBOB, 2020 to 22, President, ISOBOB, Assam Chapter, Past President, GOGS, Member, Editorial Board, New Indian Journal of Obs and Gynae. Welcome to our webinar, Madam. Over to you. Madam will be talking about postnatal blues, less recognized disorder. We welcome you, Madam.
Thank you so much. Can I share my slide?
Yes, ma'am. You can share your slide, ma'am.
Yeah. So thank you, Ms. Chairperson, Dr. Chitra, and my good friend, Dr. Sampath Kumari. And my topic is given as postnatal blues, which is less recognized disorder. And the audience have already heard Mrs. Novika, who has so beautifully told about her all doubts and how she felt about it. So we're talking about something which is also happens immediately after deliveries, the postnatal blues. Now, in 1903, where it appears acute puerperal psychosis is the manifestation of eclampsia and sepsis. Even now, sometimes we do get come across with eclampsia and sepsis with psychological manifestations. But it took us 100 years to learn that the pregnancy and puerperium are timely, sufficiently stressful to provoke mental illness. I can give you why it is less recognized. I can give you two examples. I mean, the one of my experiences. Someone who is well educated, she happens to be a doctor. She had her first delivery, and after delivery, she had some. It was a kind of intercaste marriage and some problem in the family. So immediately after delivery, she was so depressed that she wanted to commit suicide. And somehow her husband was so aware about it, so he took care of her, so things were taken care of. Another lady who was not so educated, happens to be wife of a driver, and she was little psychologically abnormal before her delivery. She had one baby before and then one abortion, and the next, when the child was delivered, within 7 days, in the evening, it was found, she was discharged from the hospital, it was found that the baby is not there. And what everybody is thinking, what happened to the baby? Actually, she has thrown the baby in a deep well. And she was looking, my child has gone, my child has gone. So this was not discovered that this was lost opportunity to find out that those postpartum problems, the depressions or postpartum, initially the blues, the differentiating between the depression, the psychosis, all these are so difficult. So we think it is to be completely normal. Now, and this by definition, this postpartum blues is the time-limited period of heightened emotional reactivity experienced by almost half a woman within first week after parturition. So this is normal, you feel it within 1 week. Now, what is the burden of the disease? Many women actually, they do not say about this postpartum stress and bear it in silence due to social stigma. They don't want to talk about it. It has been told that 85% of the new mother are affected by postpartum. Look at the number of cases, 85% as a whole in the United States. In India also, it was told that it is around 50 to 60%. The pathophysiology, we hardly know about the pathophysiology. The possibility is mother experience an abrupt decline of gonadal hormones after delivery. It may be related to a woman's sensitivity to the changes in the hormone rather than the absolute hormonal levels. Then there may be some genetic predisposition and psychological stresses. There is some change because of the hypothalamo-pituitary adrenal axis. And nowadays it has been also said that there is some potential association between the gut microbiome and perinatal mood and anxiety disorders. As all of us know, the gut microbiome is responsible for a lot of diseases nowadays. The different hormones involved are estrogen, progesterone, cortisol, tryptophan, prolactin, and thyroid hormone. I must tell you something about this thyroid hormone. The people who are hypothyroid and especially they have anti-TPO antibody, they are more prone to develop postpartum depression. The risk factors for this postpartum blues. If there is a major depression or dysthymia, in the family history of postpartum depression, history of menstrual cycle related mood changes. A lot of people had that premenstrual syndrome. So those people are also prone to these particular problems. Then larger number of lifetime pregnancies, economical condition, and relationship conflicts. The socioeconomic factors comprises of very young age, very elderly age, marital status, and obstetric factors like delivery complications, stillbirth, preterm delivery, low birth weight, as what Novika said right now. The babies, they've been so much a problem, the mother gets so depressed. The causes of postpartum blues have not been clearly established, although I have told about the pathophysiology, but it is thought to be. The most hypotheses regarding the etiology center on the intersection of the significant biological and psychosocial changes that occur with childbirth. The commonly what contribute is the fatigue after labor and delivery, caring for a newborn that require 24/7 attention. This is a real problem for a new mother, especially. The sleep deprivation is a very, very big factor. They really need a lot of support, and lack of support from the family and friends. And suppose somebody is newly married and gets a baby within few months, it is very difficult to adjust with a new family. Then, of course, the gender bias of infants, that's a big issue in our country, and the marital relationship strain. Then the changes in the home and work routines, financial stress, unrealistic expectation of self, societal or cultural pressure to bounce back quickly after pregnancy and childbirth, overwhelmed and questioning ability to care for baby. That Nabika has rightly expressed that. She was telling that whether I'll be able to take care of the baby, the doubts about yourself, anger, loss, or the guilt, especially for the parents of premature sick infants. This is one of the major factors, and we have to take care for that. These are the medical factors. I have talked about that hypothyroidism and anti-TP antibody has got a relationship with postpartum depression. And there is also a relationship between vitamin D deficiency and postpartum depression. The symptoms generally begin with a few days of childbirth and peak by day 4 or 5. It is usually said it becomes okay within 7 weeks, but maximum it can go up to 2 weeks. The clinical features vary significantly from one individual to another and from one pregnancy to the next. Many symptoms overlap with normal stress experienced by new parents and postpartum depression. It is very important that we differentiate this postpartum depression from the postpartum blues. Other symptoms of this blues are tearfulness or crying for no reason, mood swings, irritability, anxiety, questioning one's ability to care for the baby, difficulty making choices, loss of appetite, fatigue, difficulty in sleeping, difficulty in concentrating, negative mood, symptoms interspersed with period of intense joy. Sometimes you'll feel her with the tearfulness, and sometimes she is joyful. The diagnostic criteria, it's very difficult actually to define the postpartum blues diagnosis, because unlike postpartum depression, postpartum blues is not a diagnosis included in the Diagnostics and Statistical Manual of Mental Disorders. It is clinically differentiated from postpartum depression by being labeled as either adjustment disorder with depressed mood or depressive disorder not otherwise specified. And for coding purpose, it is recognized the ICD-10 diagnostic manual as postpartum depression not otherwise specified. So diagnosis, a variety of diagnostic tools in prospective and retrospective studies of postpartum blues have been implemented, including repurposing screening tools. The most important diagnostic tool is the interview. But diagnostic tool, what is used for these tools, what I'm going to speak is usually they are made to differentiate between the postpartum depression and the postpartum blues. The number one is Edinburgh Postnatal Depression Scale or EPDS. There is Big Depression Index, BDI, Maternity Blues Questionnaire, and the STAIN scale. Now I'll talk a little bit of the Edinburgh Postnatal Depression Scale, because it has got only 10 points and widely used over the European countries and a lot of in the psychological setup as well. And it is simple, of course, very, very simple. And it has 10 questions in there. The first question, say, for example, I have felt happy all the time, most of the time, no, not very often, and no, not at all. So you'll have to, she has to fill up all these points. And there are 10 points like I look forward for enjoyment, blame myself unnecessary when things, I have been anxious. And 10 questions are there, and there are 4 things where she has to tick. Now, how do you give scoring? For questions 1, 2, and 4, you score 0, 1, 2, 3 from box as from the bottom, box code as 3. From the top, it is 0. But for question 3, 5, and 10, you put reverse order from 3, then 2, then 1, and then 0. So maximum score is 30, and the possible depression is if it is 10 or greater. So this is, always look at item 10, which is the suicidal thoughts. That has to be really given importance. The differential diagnosis of this postpartum blues is postpartum anxiety, postpartum depression, postpartum psychosis, pre-existing mood disorders, and a variety of medical comorbidities can mimic or worsen postpartum blues. And it is very important that we do not think which is actually an organic disease, not a postpartum. So I always tell my postgraduate students, please, first you exclude other organic problems like there's so many things that the post-eclamptic problems or sometimes the dyselectrolytemia. Once you exclude this, then only you should level it as postpartum blues. So prevention is always better than cure. So screening is an important tool, and universal screening provides an opportunity to identify women with subclinical psychiatric conditions. And there is no specific screening recommendation for postpartum blues, as I have already told you, but you can use all those skills to rule out the specific disorders like postpartum depression. Assessment of emotional well-being during pregnancy and postpartum. The most important question that you ask is, how do you feel today? And how were you feeling last few days? This is the most important question that is to be asked to a mother. Now, what are the recommendations of different organizations? The ACOG, in 2018, ACOG recommended universal screening for depression and anxiety using a validated tool at least once during pregnancy or postpartum. Additional full assessment of mood and well-being at postpartum visit, that is after 6 weeks. This is in addition to existing recommendation for annual depression screening in all women. In the United States, it's a very, very high incidence. Then Academy of Pediatrics in 2007, the AAP recommended universal screening of mothers for postpartum depression at first, second, fourth, and 6th month well-child visit. So this is also American Academy of Pediatrics also says that. Then USPSTF, this is a United States Initiative for Cervix Task Force in 2016. They recommend depression screening in the general adult population, including pregnant and postpartum women. Their recommendation did not include guidelines for frequency of screening. So the primary prevention is what exactly Mrs. Novika said, educating the gravida. You have to tell the patient, the counseling is very, very important part. Then educated the family and friends. You must tell the family that how the emotionally how a newly mother is labile. And in most of the cases, we have seen the grandmother or the mother-in-law becomes a big problem. Actually, she creates the whole problem in a lot of situations. That is my practical experience. And I always feel that those mothers who are so vulnerable, they are they should have a good family support system. I always tell them to go to their mom's place. And I think it is a very good decision in some of the families, they have a system that the first delivery should be at the mother's place. I think this is a very good system to have a very good, the emotional status of the mother. Reassurance, emotional support, which is very important, and adequate rest, family planning, counseling is also important. Now, the most important thing managing postpartum blues is early identification of symptoms. It should not go to the postpartum depression to that level, and prompt intervention, that you give them enough support. Then facilitation of open discussion with patient and their families. And of course, you have to have access to mental health and resources and professionals. And treatment, all of us know, it is a self-limiting condition, but it requires no treatment other than validation, education, reassurance, and psychological support, which is given by the attending doctors, the nurses. Nurses are very good psychosocial supports. And of course, the family members who understand her, very, very important. And of course, education is very, very important. And you have to reassure that this is not going to be there for a very short period of time. And recommendation to relieve the symptoms are getting enough sleep, taking time to relax and do activities that she enjoys, asking for help from family and friends, reaching out to other new parents. I think the support system of the new parents also brings a good support. Avoiding alcohol and other drugs that may worsen mood symptoms, reassurance that symptoms are very common and will resolve on their own. So, this is a self-limiting condition. It is significant to carry out follow-up. Up to 20% of these mothers are likely to progress to postpartum depression. You have to be very vigilant. According to DSM-5, the risk of postpartum depression significantly increases in those who had mood or anxiety symptoms during pregnancy. An adverse consequence of children's cognitive growth is also told. The complications are increased risk of developing postpartum depression and postpartum psychosis, higher levels of comorbid anxiety, and there is a chance of development of bipolar disorder in future. So to conclude, you must exclude with postpartum blues and depression are screened for the suicidal ideation, homicidal ideation towards the infant, paranoia, and para or pre-psychotic thoughts. You must screen for this because these are dangerous and these are a part of the pure psychological disorders and they need intervention. So the conclusion, the primary care setting is usually the predominant location in which the postpartum blues are first diagnosed. So primary care facility has the importance, they must diagnose it. And primary care providers, including obstetrician, must be knowledgeable in the symptoms of postpartum blues and adept in its diagnosis and management. Thank you so much for a patient hearing.
Shashwat ma'am, fantastic. Have taken a beautiful class, madam, regarding that postpartum blues.
Thank you. Thank you so much.
Ma'am, we had one question. They've asked, are you seeing more of postpartum depression and postpartum blues in COVID scenario?
This is definitely a question because a lot of people, I have seen people are doing a termination of pregnancy. We don't want to have a baby during these COVID periods. The pregnancy, they come with that fear of having some problem with the baby. And the support system is also been much affected. The support system, the people cannot come because of the lockdown and so many things. So definitely the depression, the postpartum psychosis, I won't say the psychosis is, I have seen a lot of them, but definitely these part of depression, there is a chance and they could need a good follow-up.
Any further add-ons from the chairpersons, ma'am?
Yes, only one point, madam. I want Shashwat madam has explained everything on the etiology, causes and everything. If an anemia patient delivered and she is behaving with mood swings in the postnatal ward means, usually the juniors will think that it is as a case of postpartum psychosis. But the anemia patient delivered, we have to think of cerebral thrombosis also. That is the only point I want to add.
Yes, I told everyone before putting them in psychosis, you must exclude all medical problems. That is most important. Sepsis is also one thing that can cause that kind of, psychotic problem.
Thank you.
I would like to add on, ma'am. Actually, pediatrician should be the first person to recognize because they come on the 4th or 5th day. I usually think when they have this breastfeeding issues, too much visits to us, then I think whether we have to rule out. So I think pediatricians should also be made aware of the postpartum blues because we have to treat them as a pair. So that is why I thought it was a...
Yes, the recommendation I have given you, the American Academy of Pediatrics, they say that this is also a part of their follow-up. They should also follow up the mother.
Very true.
Thank you so much. Thank you so much for allowing me to be a part of this conference.
Ma'am, we are also very thankful for this wonderful lecture, which is very lucid and clear. This is our e-memento for you. Hope we could meet you physically in the future. Thank you so much, ma'am. Thank you. Over to Dr. Chitra, ma'am, for the next speaker.
Yes.
Will be Sampath Madam will be introducing the next.
Yeah,
After the wonderful talk of the postpartum blues, now we will go to the next speaker. Next speaker is none other than Dr. Sujata Mishra. She is the superintendent and professor and unit head of the Odisha College. And she was the vice president of FOXI in 2015 and secretary of Association of OG from 2012 to 19, chairperson of Medical Disorder Committee of FOXI from 2009 to 2012. Academic counselor, postgraduate diploma in MCH course and IGNOU. Her special recognition is principal investigator in Cuttack site and WHO Champion Trial, WHO Action Trial 1 and 2, and co-investigator in Cuttack site of Life Trial and Life Trial Extension. She has received the award of Radhanatha Award for Humanitarian Services. Her field of interest is medical disorder in pregnancy. She has many publications to her credit. Now we can hear from Sujata Mishra about the postnatal fitness and the family life and getting back to the normalcy after delivery. Now, Sujata Madam, it's yours. Stage is yours. Dr. Sujata?
Dr. Sujata, ma'am?
Dr. Sujata Mishra?
1 minute, ma'am, I'll find out. She's there, ma'am. She's there. Her video is also on. Sujata, ma'am? I'll give her a call. Maybe.
Sujata, unmute yourself.
Good evening, everybody. Am I audible?
Yes, ma'am. Yes.
Okay. So, can I start screen sharing now?
Yes, ma'am. Yes, ma'am.
I will. So, while I open up my presentation, a very good evening and my regards to Dr. Jayalal, Dr. Lele, to all the organizers, Dr. Narmada for having me here, Dr. Nivedita Pani, who was the president of Orissa branch IMA, and of course, my friends from FOXI, Dr. Dilip Datta, and everybody else. So it's very nice to have Sampath Kumari, everybody here, Shashwati, etc. All of them have been my friends. Is my slide visible? May I start now?
No, slide is not visible.
Oh, you have to share your screen, ma'am.
Yeah, I did share. 1 second. Let me just do it. Just let me do it. 1 second, please. I'm sorry for the delay. If I'll just get back to you. Yeah, yes, that should be good.
Yes, ma'am. Good, ma'am. You have to put in the slideshow.
Yeah, 1 second. I'll just do it. So now, thank you, Shashwati. You really made my work so much more simpler, because you know what? Postpartum now is going to be a very important issue now that we've tackled antenatal to quite an extent, and safe motherhood is both with postpartum and antepartum. Now, thank you, everybody. Lovely program. We know that motherhood is the greatest thing and also the hardest thing. Now, the postnatal fitness and family life, getting back to normalcy, is indeed a challenge. What happens at this point of time is your uterus is trying to get back to normal, your breasts are trying to act well, your various glands and capillaries and vessels all are trying to get back to normal. And we have certain post-pregnancy questions. How does pregnancy really affect the body? What's all this talk about the pelvic floor? When can I start working out? When will I get my periods again? What if I conceive just in case I have intercourse? There's so many more things. And I really feel that we really need to have special classes for them. True, we give postnatal checkup. True, people come back to us. But it needs so much more than what we tell them at this point of time. Now, what happens following delivery? Everybody was very anxious. We took care of all the trimesters. We did all the ultrasounds. We told her what she should eat. But in the end, after the delivery, God willing, everything went fine. You have a tearful, happy, but overwhelmed, and an emotionally fragile. I love this word. The lady now we have is an emotionally fragile woman. Many of them have symptoms of desperation and loneliness because of the hormonal changes. Along with that is the stress. Now these children are very smart. Gone are our days when we were, a little more adjustive, a little more ignorant maybe. Children know everything nowadays, and each one wants to be perfect. And this desire to be perfect in every field and not asking for help, thinking that I can do it, leads to a lot of stress and isolation and sleep deprivation and fatigue. As Professor Shashwati said, all these things start within the first couple of days and taper on by the end of second week. But this is extremely important. So what do we need to look at, apart from depression, which has already been said, the fatigue? This is from Williams' textbook of Obstetrics. Fatigue is 59% in postnatal women, and the least of the complications are vaginal discharges. In between, you have breast problems, anemia, backache, hemorrhoids, headache, postpartum blue, constipation, suture breakdown, etc., etc. Now, every body is different. As Navika said, that you can't have one size fits all. Now, how that particular lady is going to, react, respond, behave after her delivery depends a lot on how she was towards the end of her pregnancy. Did she have a proper quota of intake of macro and micronutrients? Did she have a normal delivery along with a bad or a healthy episiotomy or a tear or prolonged labor or C-section? All of them will add to how she feels later on. The minor issues of back pain, hemorrhoids, constipation, varicosities can be dealt with. She has to cope with fatigue initially. So what do you tell your patients the minute they deliver? We need to tell them, sleep whenever you can. There is no day or night for you in the first few months. Sleep when your baby sleeps. Along with that, once you start feeling better, try to do some kind of adult activity for 45 minutes. Start with 15 minutes, 20 minutes. This is just a feel-good factor. Everybody is concerned till you have delivered. After you have delivered, they think, the problem is now over. Now she's there with the baby. We will give our support, but that emotional support has to be given by the spouse and the parents. How long does it really take for a woman's body to return to the pre-pregnancy states? Entire first 6 weeks is, in between healing, rebalancing, and recovery. The genitalia, the genital organs usually return to their original size and function by 6 weeks to 2 months. Hormone relaxin, it's there up till 5 months. It may not be very, you wouldn't really know that it's there, but what it does is, increases the size, elasticity of the connective tissue, ligaments, muscles, and hence we do not tell them to do high impact activity. It will put tremendous stress on the pelvic floor and abdominal organs. So as much as we would say, go back to activity, go back to certain exercises, which exercises, when, what kind of lifestyle modification she should adapt should always be subjective to her doctor's advice. Many of the ladies have divarication of the rectus abdominis, which takes about 6 weeks to heal. It's totally physiological. It happens with this overbulging of a big pregnant uterus, which leads to a divarication, not in all cases, but where the muscle is weak, where there is bad posture, hence the need of advising a good posture and adopting a good stature even in the antenatal period, and not to kind of walk with your spine bent and your belly out. Limit exercise to gentle pelvic floor and abdominal exercises initially. 8 weeks later, you can begin stoning exercises in 15-minute sessions, building up by 5 minutes a week following that. Aerobics and low impact going on to high impact can wait to a couple of 5 to 6 months after childbirth. Now, some ladies will say, no, I really wanted a vaginal birth. I tried so hard and I told my obstetrician I want a vaginal delivery, but I landed up with a cesarean. Now, in present times, what we decide depends on what is required for you at that point of time and what is good for the baby and for the mother. And whether you have a vaginal delivery or a cesarean section, that should not affect the mother at all. Of course, the recovery to normalcy is a little different. In a vaginal delivery, the problems are more with the genitalia and the area of the episiotomy, that's a perineal area. Sexual intercourse is definitely a little more challenging. While in a cesarean, for the first 4 to 5 days, it's the wound problem, the itch and the burn. But anyway, you can go back to your exercise program in a very stepped fashion, starting from about 10 to 12 weeks. What about postpartum incontinence? I would like my august audience to note that every point that I'm touching on has to be told in the postnatal period if we want that lady to improve her lifestyle. And these will all summate towards an altered lifestyle and hence a better family life in the postpartum period. Now, following a prolonged labor, at times there is some urinary incontinence. At times there will be some anal stress incontinence also because of a, not properly performed episiotomy wound or a tear. I would not like to think of it, which extended. It does happen more so if you have your, some of the paramedics delivering. It can happen, but it will heal. It can be addressed. There is no need to panic about it. The best exercise that can be started very early following delivery, whatever may be your route of delivery, may be a cesarean or a vaginal delivery, is the perineal floor exercise, well known to all, or the Kegel's exercise that really helps in toning up the lax perineal muscles and bones. Now, weight. Everybody wants to have that, typical a nice figure, and this delivery has really altered my appearance. It's gone for a toss. My weight has really increased. Not to worry. Don't go on a crash diet. Whatever you gain during delivery, it includes the uterine, the muscle mass, the fluid retention, the various organs that had to develop because you have to feed your baby and you had to give the best nutrition to the baby. It will all gradually go back. It is just the awareness that is required. A lot depends upon your pre-pregnancy weight. Please don't go overboard during your antenatal period when everybody tells you, eat for two, and you just eat. Eat the right thing in the right proportion, and you would never gain more than 9 to 11 kgs, which we want a normal pregnant woman to gain. If a lady is obese from the very beginning in the antenatal period, we don't even look at 9 to 11 kilograms. We look at around 7 to 8 kilograms of weight all throughout the 9 months. Now, so what happens to the weight once you've delivered? 1/3 of them will gain their normal weight by about 3 months. Those who are borderline overweight to obese, they would probably take a little longer. The best way to lose weight is breastfeed your baby, and you lose a whole lot of calories every day. So breastfeeding is the best way to lose and shed off some of the calories which you want to lose in the postpartum period. Lose weight safely. Consult your doctor. Do not do it too quickly. It can affect your breast milk supply. Do not take any diet pills. They contain harmful drugs, and that can be passed on to the breast milk, though the amount will be very little. So as I said, in your endeavor to lose your weight, do not forget the healthy eating tips. Eat a variety of food, balanced diet of fruit, vegetables, grains, proteins. Plenty of fluid intake, about 6 to 10 glasses per day. Protein-rich food is required, and take your prenatal vitamins, but do away with limited, not even limit, just limit the junk food. Don't take them at all. Once in a while is okay, but this is where you have a problem. Now, what exercises would you do after pregnancy? if you exercise whatever you can, start with Kegels, then start with just postural ones, then start with a little bit of toning, then go on to yoga, as and when you heal from all the postnatal period takes you more towards normalcy, it'll lift your spirits, it'll improve your posture, it'll help build your muscle tone and strength, and it'll lead to a good sleep. Best way would be walking, because it puts very little stress on your body. Walk briskly for 20 to 30 minutes every day, or at least 3 times a week. It could be in the hall, it could be in your room, it could be in a garden outside. Of course, with all the COVID restrictions and COVID appropriate behavior, we would not like you to go out. Just walk around your rooms, walk around the house, inside the house. And later on, if your baby wants to really cooperate with you, you can join for the mother-baby yoga classes. Basically, the mother does the yoga and the baby lies in there. Now, what is more important is, when I talk of lifestyle modification, I definitely cannot leave behind postpartum sex and contraception. How long after childbirth can we have a sexual intercourse? These things have a taboo. They would not like to talk unless it goes to a point of ill repair when they come back and tell the doctor. So why don't we tell them earlier that these are the problems? I think there has to be a very structured lifestyle modification advice given to every woman after she delivers. Can she take contraception? Which contraceptive would be the best for her? What about coitus? As we all know, it's very physiological. It's a part of a couple's way of relaxing, and one cannot do without it for very, very prolonged periods. Of course, it is not advocated immediately, but surprisingly, all the research articles which I went through while I was preparing for this talk said it should be 6 weeks, 2 months. But our textbook, the Williams textbook of Obstetrics, says it just is best to use common sense. After 2 weeks, coitus may be resumed, but it is based on desire, based on your comfort level. So there is no clear-cut dictum as to when you can start doing it and when you should not and when you can. So talking about these marital issues, which is looming large nowadays, there are 8 marriage issues which one faces. What happens is, from a coupledom, now you go to a baby environment. This is exciting, exhilarating, and wonderful because this couple was waiting for it. But it's also exhausting, exasperating, and worrisome. A combination that can be toxic to the most romantic relationship that made you parents in the first place. So maintaining a marriage post-baby takes a lot of time and energy is what you definitely do not have following delivery. So we should work on our relationships. Please do not think that this energy is going wasted. We have to learn to enjoy this together. Following childbirth, your domestic duties double. Your parenting styles will differ. You will say one thing, your husband will say one thing, your parents would say one thing, your in-laws would say one thing. You have sex half as often, and it's twice the hassle also because of the aches and pains and your exertion and exhaustion. And then what happens? It often goes to the point of no return and divorce. What was earlier the couple time has now become the family time. You get no time off on your own. If you are not working now and you were working earlier, even money matters more than what you had thought. These are all very, very important issues. You both are parents now, but you, the mother, you are still yourself. So which brings me back to where we had started. We need lifestyles modification. Certain research articles have shown that 1/5 of couples, more in the Western countries, break up during the 12 months after welcoming their new arrival because of dwindling sex life. Some couples are lucky and despite more than 1 in 10 resort to a trial separation and yet get back together. But in other cases where there were deep-rooted issues earlier, it's difficult for them to overcome this problem. Hence the need to counsel, hence the need to tell them, look, these things are normal. You're not the only one who's going to witness this or experience this, and this is the way we need to get out of it. Women often think that what they say needs to be taken care of, the other person will volunteer. But as Carol Amel has said, men often respond better to direct requests. So please go ahead and place your request rather than presuming I have said this, that I want this, and he will understand and do it. There is no place for riddles. Let's be upfront as to what we need to help us. Now, this is a particular journal. I mean, I would tell you what they saw, because this is as late as April 2021. And what all did they do in this? From this particular work, they concluded that a healthy postpartum lifestyle is vital for the promotion of optimal maternal health. Return to pre-pregnancy weight and prevention of postpartum weight retention is important, of course. They did a systematic review to describe the barriers and facilitators to a healthy lifestyle in the first 2 years postpartum from the perspective of the woman and the perspective of the healthcare provider. They looked at 28 qualitative and quantitative studies after screening almost 15,643 citations and 246 full tests. So what I'm saying here is not out of my experience or my figment of imagination or what the standard textbooks have told me, but there's a lot of research which has gone into postpartum lifestyle monitoring and modification. Number one, there's a lack of knowledge regarding the benefits of lifestyle behavior, and we need to focus on this now. We need not wait for the 6 weeks postpartum when she comes back, when the damage has already been done. During discharge and maybe a little later, we have to talk about all the issues. There's a limitation in the healthcare provider skills in providing lifestyle support because probably we have not discussed so much about it. All the opportunities like social support should be made available. She should be motivated and told about the benefits of exercise and perception of her own personal health, her enjoyment of what is good for her, her enjoyment of the food that she likes, and her enjoyment of what activity she wants to do. Suggest intervention components to include in lifestyle interventions for postpartum women based on the needs as related to her, as identified as her needs. And findings provide evidence to inform the development of interventions to support postpartum women in adopting and maintaining a healthy lifestyle. So friends, all those things that particular couple had thought about each other, all the flaws that they had earlier would still be there. Now there's a baby, now they are a family, and a lot of onus rests on us to see that we can help them with lifestyle modifications and give them a very good quality of physical life index. Thank you so much for a very patient listening. Over to you, Dr. Sampath Kumari.
Yes, Dr. Tata, excellent talk, practical information. As you told, it is very, very important. After the postnatal period, the weight gain, the small puerperal sterilization, then they will tell that I have put on weight. Next, about the sex, it has to be counseled to the patient. Fantastic talk, Dr.
Thank you.
Ma'am, Dr. Anamika Pandey has asked why there hasn't been any recommendation that includes and highlights the necessary counseling of husband to be compassionate and extra supportive for postpartum period.
Well, it's not that it is not there. As I said during my talk, every time we start that from our antenatal classes. Why wait till the postnatal? Now antenatal classes are all very structured. Now, the postnatal classes also are there, but they need to be a little more structured, and we should not think that the doctors can do everything. We have to reach it out to the nurses, to the paramedics, to the Anganwadi workers, to the Ashas. They also should be a part of this counseling, you know. It's not that only those who can come to us, because it's seen more in the lower middle and middle class, right? Because the others in the antenatal classes, we have the husbands coming with them also, you know, so they do share the burden. And there is no dictum which says that postnatal burdens should not. It has to be shared. There has to be a division. You cannot do tit for tat. You won't say, I did this, so you did do this. They have to sit together and see what works out best for them in such a manner that the husband's work is not affected, yet he can give her some time off to herself. Thank you.
Very true, ma'am. Nowadays, young girls want to be fit very soon, but then they start compromising on the breastfeeding. So we as a pediatricians are more worried about that. So that's why this topic is more relevant for both the obstetricians and pediatricians. Thank you.
I thank you for giving me that topic, Dr. Narmada.
Thanks, ma'am. Ma'am, I thank you for taking it up. So when you asked me initially, I asked you to touch upon that because with the problems that we were facing, it was so beautifully dealt with that. And I have many of my friends who went into even divorce because of their postnatal problems. So I thought, thank you so much for taking it up and touching on this topic. And this is our real thanks for you for such an excellent deliberation. Thank you on behalf of the Motherhood program coordinators. Okay, ma'am.
Over to the third speaker.
Yeah.
You can project the CV of Dr. Leela Vyas.
Yes, ma'am. 1 second, ma'am. Sorry, I just.
So we had talks about postnatal blues and postnatal fitness. Now we will go to the third talk by Dr. Leela Vyas. She's the former senior professor and unit head and IVF consultant, SMS Medical College, Jaipur, and senior consultant, Kukun Hospital, Jaipur, and senior consultant, aesthetic and cosmetic gynecology at Vyas Hospital, Jaipur. And Dakshita and Lakshaya mentor, NHM, Rajasthan. Organizational position, she is a chairperson of ISA, Rajasthan, vice president, FOXY on 2018. I was lucky to work under her. I was an adolescent committee chairperson when Leela Vyas madam was a vice president of FOXY. And she was the president of Nachi, Rajasthan, 2016 to 17, president of Jaipur OBGYN Society, 2013 to 15, and secretary, Jaipur OBGYN Society, 2005 to 2007. And Dr. Leela Vyas is main champion of Manyata program, that is to the private hospitals. And she is a main mentor for that Lakshaya capacity building with FOXY. Now, Leela Vyas madam will be talking about postnatal persistence of antenatal problem. We can hear. Madam, Dr. Leela madam, stage is yours.
Thank you very much, Dr. Sampath, for this nice introduction. And really, you have not worked under me. So we worked together and we enjoyed that. And adolescent health, we enjoyed in a way that you have organized the programs. So thank you, National IMA that giving this opportunity to present before you this topic, which is a postnatal persistence of antenatal problems. And thank you to Dr. Datta sir, and Dr. Jailal sir that giving this opportunity. And definitely it's a very right way to connect through this. We are all going with the FOXY, but this IMA should, if coming, then pediatrician, we are coming all together. So thank you everyone for this organizing this CME. I'll share my screen. Before me, the speakers, those who have spoken about that postpartum blues and then health perspective regarding the postpartum period. And Dr. Sujata has already told that it requires a more and more attention towards the postnatal care. So if you go with it, see that the postnatal care programs are the weakest of among all reproductive and child health programs. We have seen once a lady delivered, it's a very less time has been expended with that. We all know that this program is not very So even where the strong public health programs are in place across the life course, because our target is of a lady's health to be taken from the adolescent to adulthood, reproductive, then their different phases of life, but still they do not guarantee that women enters in pregnancy in good health, because so preconceptional part, and then this is not there. So once we get an unwanted pregnancy, why it is increasing, we all know that in postpartum care, if you go with this, all aspects of her health regarding the contraceptives and all these things, so we can prevent the next pregnancy as per her choice, not of by the chance. So this program, we have to think of that. So that's why we think why to invest in the postnatal program, because the running and the actual situation is that we are not spending much on this antenatal part, because all of our, we have seen that entire emphasis and vigilance is on the antenatal period. And postnatal period, the mothers are neglected, because our just attention go towards to the baby. So this baby becomes the more important as compared to the mother. So mother's health is required. In previous lectures, we have seen that Dr. Sujata has told that how we have to go with, to talk with that in every aspect of their life. And before that, as Dr. Saswati has said, the postpartum blues, it has been neglected. It is very rarely it is diagnosed. Just say that this and that, we go with all these things. Because if you talk about this northern part of the India, if a second girl child is one of the problem, which creates so much of their anxiety in their part. And if you see a lady is a second gravida coming to us, having a first female child, the all social pressure is on that. This is a very common factor, because these are the ladies, they come with the under depression, and we are not giving attention to these ladies. So this postnatal period for the mother's care is required, because we have to explain everything. So our motto is the promotion of this lifelong wellness of a lady. And for that, we have to take care that once, because as in our situations, the female is not coming. Means so many programs regarding the preconceptions we see. But if once lady delivers, how she has to proceed for the second time pregnancy, that they should have a desired one, not of by chance only. Then yes, we have this. I'm not saying that against that we should not take care of the baby. The infant care is so important, but in relation with the mother, we should not neglect any of the one part. We have to hand in hand, mother and baby both to be taken. So WHO, we all know that they have given that there should be 3 visits. Why I'm talking about the 48 to 72 hours? Because sometimes after the delivery of the baby, within 24 hours, they move away. So this one period is up to 72 hours patient, the lady who has delivered to be taken. Between 7 to 14 days, another visit should be there, and next visit as the 6 weeks. So usually this 7 to 14 days visits has been missed, and there's so many problems which they are directly coming to the 6 weeks, because it happens into the busy medical colleges OPDs that we are not calling them at the 7th day, in between the 7 to 14 days. Then NHM is doing very good work, and there are so many recommendations, and the ASHA workers are doing these all work. So ASHA workers, they are going for that. The instruction has been given 3rd, 7th, 14, 21, 28, 42 days. This, and once every 2 weeks until to the baby becomes 2 years old. But we know that the problems which are coming from the first in the antenatal part, the ASHA worker will not able to. She can only counsel that. The simple thing, she is not taking blood pressure. So, and that there we require either the A&M is to be going, or the medical or the paramedical things are to be given. So we need that these programs are going on, but the various studies are showing, because all these structures program, we are not getting a good results. So we have to think over it, how to promote our maternal part of these antenatal problems which are persistent to the postnatal part. And when I was going through this topic, there was a very limited studies were available. The thing is, because we are not concerned about that, and practically we have seen that in working with all these part, the importance which we have to give is very limited. So again, we go with the anemia, which is the one of the major problem in our country. We are the very less studies is available regarding this, how they are going. So there are some studies. If we go with some Rajasthan studies, we have seen that most of the common cause of maternal morbidity in the early postpartum period is anemia. And the various national surveys, DLHS or NFSHS, they have done, and they have found that postnatal hemoglobin estimation is not commonly done in these patients. And by the various studies, we have found that 1/4 of the mothers who had normal hemoglobin level during their third trimester, they have developed the anemia in their postnatal period. In India, the prevalence of postnatal anemia is around 65%. And there are studies from the other countries also. In the developing countries, we have seen that 50 to 80%. So this problem is not only in the India, but in the all developing countries are there. And if we think of that, in Indian scenario, there is some transition of epidemiological transition towards a non-communicable disease. Why? We have not given any thought. As an obstetrician, it becomes our responsibility to see that the cardiovascular disease accounts for the most of the deaths in females. And onset is very typically early, and the case fatality rate is high. So we have to think why this non-communicable diseases are coming in our country is much of this. So we are somewhere responsible. So the pregnancies which are related conditions such as preeclampsia and GDM these are associated with the significant perinatal mortality and morbidity, and they carry an independent risk for the future cardiometabolic disorders in mother. So we always take care of that. If in antenatal part they have some problem of preeclampsia and eclampsia, we have to take care of that and how to counsel our patients to what precautions we have to take. So the various studies have shown that there are 4-fold risk of developing chronic hypertension post-pregnancy and 2-fold risk of ischemic heart diseases and stroke. And if lady having the GDM, they develop the type 2 diabetes at an early ages. There are few studies showing that approximately 10 years earlier, they can develop if it is not properly taken care, even in the postpartum period. And even that, we all know the Indian ethnicity is the one of the factor. Because of that, we are 11.5 times more higher chances of having GDM. And the only risk factor is the Indian ethnicity. So the body mass index, so obesity is not only the factor. We have the lean and thin lady can have this GDM and they carry these high risk for the coronary artery disease. So this is the something which is different from the other nations which we Indians are facing. So, and practically we have seen that GDM is the area of the low concern in rural especially, and as well as in the some urban populations. You must be knowing as Dr. Sampath Kumari is also with me as a champion for this Manyata assessment. We have seen that how we are promoting in the urban areas about the GDM. So diagnosis of GDM and all these conditions is not very commonly done in even a big corporate hospitals. Still they follow that the random blood sugar estimations and all. So we miss these conditions in the antenatal, and the postnatal, it is not very much taken care by that. So women with the pregnancies which are complicated by the GDM or with the hypertension should be counseled that these disorders are associated with a higher lifetime risk of maternal cardiometabolic diseases. And so what we have to do in all these conditions, that we should go with some plan like that. These patients should be taken care of that. As in my previous lecture about the health. So the weight and different part, their diet, that has to be taken care of that. These things will help into maintaining the postnatal health of the lady. So there are various studies which are saying that antenatal and postnatal care and the various studies to be done for the in developing countries, as well as if you talk about that postpartum care is also taken by the very developed countries like US And this ACOG has been given this presidential task force. They have given this committee opinion regarding this postnatal care. So the ACOG said that to optimize the health of the women and the infants, postpartum care should become an ongoing process. It should not be only for that, only for the 6 weeks or the first visit or second visit, everything is okay, we can leave that patient. No, we have to, but this process should be ongoing, and it is then with service and support which is to be tailored to the each woman as per their individual need. Means if any a low risk lady is there, how to plan their visits and how to counsel them, and any of the lady which is having the high risk problems, that we have to take care. And then so this postnatal care should be tailored as per their individuals. So anticipatory guidelines should begin during pregnancy with the development of the postpartum care plan that addresses the transition to the parenthood and well-women care. That has been already explained by Dr. Sujata, that what all counseling we have to do in their antenatal part. So prenatal discussion should include the women's reproductive life plans. That's why, so including the desire for the timing of the future pregnancy. We all know that if very frequently they have pregnancy, one of the factors that is the anemia and this generalized nutritional deficiency, which reoccurs, and the persistent morbidity persists in that women. And then we have the all complication of preterm birth, IUGR, and other problems the lady will have. A woman of a future pregnancy intention provide a context for the shared decision making regarding contraceptive options. So these are the where we have to use and how we have to delay the next pregnancy and when the patient should conceive. That is to be done all these during their antenatal period. So the postnatal is not to be separated from the antenatal. It is the postnatal advice to be started from there. So all women should ideally have the contact with the maternal care providers within the first 3 weeks postpartum, and this initial assessment should be followed up with the ongoing care as needed into this comprehensive postpartum visit later to the 12 weeks after the birth. The timing of comprehensive postpartum visit should be individualized and the women-centered. So we have to think what the detailed history to be have in your hand, and then you should explain what should be the further time of their visit. This comprehensive postpartum visit should include full assessment of physical, social, and psychological well-being, because the previous speakers has explained everything that how important the postpartum period is that. And these guidelines, if we follow in our, because it's not only for the developed countries, because in the developing countries, more and more attention is required into the postpartum period. So these pregnancies, as we have told, complicated with the preterm birth, because we all know that the reputation may be there, the gestational diabetes, hypertensive disorder, they should be counseled that these disorders are associated with the higher risk in the life health process. So these women with the chronic medical conditions. So one is the condition which is pregnancy induced, which occurred in the antenatal period, that is actually, and the medical disorder, the pre-existing with the pregnancy. These are the conditions, because as the time has come, the late pregnancies are there. We are getting majority of the pregnant girls are coming at the 31st pregnancy occurs at the 30 years of age. So this incidence of chronic hypertension, then diabetes, type 2 or type 1 diabetes, thyroid disorders, renal disease, even we see the patients with the renal transplants, mood disorders, because of the all social pressures, work pressures, they made them to their mental health to be disturbed. Substance use disorders, which is again a one to be taken under consideration and should be counseled regarding the importance of timely follow-up with their obstetrician and gynecologists or the primary care providers for the ongoing coordination care. So this all conditions, so the optimizing care and support for the postpartum families will require the policy changes, because we see that the different health policies are working that just finishes after their pregnancy is finishes. So in one visit of the postpartum, everything has to be there from their pocket. So again, there should be some changes in the policies that the lady can have these facilities in ongoing postpartum period. So that I think that will help. In some government policies, they are again taking care of mother and the babies. But in the private sector, again, we have to see all these things, and then we should advise and we should recommend all these policy holders and then stakeholders that should be included into this postpartum care. So to optimize the health of the women and the infants, the postpartum care should become an ongoing process rather than a single encounter, with the services and the support tailored to each woman's individual life. So I just conclude it here, because the antenatal problems main common which we are dealing with, that one is the anemia, which is even not anemic becomes the anemic, the PIH, which again is one of the problem, and GDM, which is we as a this capital of diabetes, we are the primary preventer, and we can do all these things. So, and just I finished my talk here talking about this, and now I need some expert comments from our chairpersons to add on this topic, because there's so many literature is not available. It becomes our responsibility to do the more and more studies and put forward these literatures among our colleagues.
Yeah, ma'am. Beautiful presentation. You have covered everything. As you told that anemia, GDM, PAH, everything has to be. The main thing, as you told, the postnatal persistence, the contraceptive advice is very, very important to postnatal persistence of antenatal problems. That is the only thing.
That is because we are getting all these patients. Once previous cesarean, 3 months old baby, and they're coming with the pregnancy. This is the one of the problem which we are dealing. So, in the preconceptional counseling, which we are doing for young girls, but here we have the opportunity that we can avoid the pregnancy by chance. It should be a planned one. That is to be.
After the diagnostic, definitely that single step sugar value has to be seen, madam, in the GDM, as you told. Otherwise, the diabetes will be increasing, and the anemia. Usually, I used to tell always, when a girl is 12 years, hemoglobin should be 12 grams. So the anemia has to be corrected from adolescence. So if the antenatal means in the postnatal, anemia will be little worse. So it has to also to be taken care, madam. You have covered everything, I think.
And there has been a question.
Madam, wonderful presentation. Madam, I want to add 2-3 points in this. In this corona pandemic, we are limiting our antenatal visits, and we are discharging our patients early after delivery, and postnatal visits also it is restricted. So we must advise and we must promote teleconsultations. And then for PAH patients and diabetes patients, we can encourage home BP monitoring and sugar monitoring also. Then another point also, we must encourage and teach our healthcare providers to identify the mental health problem as well as the physical problems. And then regarding the mental health problems, we are not having a prominent component in the mental health program. Our maternal mental health must be included in that. Otherwise, we can't improve all these aspects, because we are in this corona pandemic. These problems will go on and on. So thank you so much.
Yes, ma'am. Nowadays, the BP measurement is also at home they are doing, and they are telling. So that we have to give the importance of that. And again, that part diet and the other part has been already covered. So I have not included that, and that helps in their maintenance of the health, and then we can prevent all these medical disorders which are very common among our people. Thank you, ma'am. Thank you very much.
Ma'am, there are 2 questions, ma'am. There is a question on, can we have a day-wise agenda of a 48-hour stay under JSY institutional delivery? By Dr. Abhinav has asked.
Yes, in JSY, the delivery that they require the 48 hours, minimum of the 48 hours stay. But the majority, if you go, I'm not talking about the medical college or the district hospital, even in the district, the medical college, because being a teaching hospital, they always discharge the patient after the 48 hours, because our pediatricians are there, they will not allow to discharge these patients. But in the small centers, in the PSCs, CSCs, the all rural public, they come and they want to go, they will say, we'll come one day after and we'll sign it. When the COVID, we have seen the patient delivered in the at home, and the entry has been done on that, because they are all scared of that, because they don't want to come these things. So this is a very strict that 48 hours we have not to be discharged. Even in the some corporate hospital, we have seen, because of some policy matters, if patient has been admitted before 2 days before in hospital and her package is finishing on that, even I have seen less than 48 hours they have been discharged. So that is to be mandatory, that you have to keep the patient at least for. As a pediatrician, what is your take on that? The when to discharge the baby?
I would definitely say one more day I will add on, ma'am, because neonatal hyperbilirubinemia is being missed.
Yes.
People come on 3rd or 4th day. At that time, I have seen one baby went in for a neonatal encephalopathy because of the mother being discharged with less than like 24 hours for normal delivery. She was not, she did not go back to the pediatrician. By the time she went back, the bilirubin levels had already crossed. So the neonatal encephalopathy is there. There are a lot of feeding problems are there. So we definitely feel we need one more time for appropriate lactation counseling as well as ruling out neonatal encephalopathy.
Yes.
Ma'am, there is one more question, ma'am. They have asked when MMA drugs are safe in postpartum period.
Pardon?
Ma'am, they've asked when MMA drugs are safe in PNC period. I don't know what is that. Dr. Abhinav has asked.
Abhinav, what is MMA drugs?
Medical. The MMA is medical termination of pregnancy. We are using mifepristone and misoprostol now, madam.
Okay, that the medical termination of the pregnancy in postpartum period means lactating mother. I think he must be. Yes, lactating period. Ideally we should stop lactation for 2 days and then only give. But the majority of the time, the patient, we all know, they get medicine from open counters and they are taking themselves. But yes, in the breast secretion, the drugs can come. So it is contraindicated during the lactating phase.
Okay, ma'am. These were the 2 questions. So anything else?
Yes.
Thank you, ma'am. Thank you so much, ma'am. And we really are very thankful for you for having joined us for this program. And this is our appreciation for your time.
Thank you very much.
Thank you so much, Leela, ma'am. Thanks a lot.
Thank you.
So I thank the chairpersons too for their excellent contribution to the program and adding on their views on this. So, Chitra ma'am, our thanks for you. Chitra ma'am, thank you so much for being the moderator, and Dr. Sampath Kumari ma'am, thank you so much, and thank you for adding on your experiences also. It's been a pleasure to have you both as a moderators, and all the speakers who have contributed their time and shared their experiences and touched on very interesting topics and kept us glued for the past 1 hour. Thank you so much. Now I would like to hand it over to Dr. Erika Patel, the National Coordinator for Safe Motherhood Program, for her final comments.
Thank you so much, Dr. Narmada. And all the speakers and all the chairpersons, excellent discussion. I think it is so very important to give more focus to the postnatal period, because there's a lot that goes on, and the entire attention from everyone in the house is only to the baby. So it is very, very important that we take care of the mother. I would ask Dr. Dilip Kumar Datta sir to give his final comment.
No, thank you, our chairperson, Sampath Bhai, everything, and Joyla sir. One important issue in the postpartum period, other than the lactation and other things, we are very much worried about the pregnancy that comes in the rural area during the lactating period, and there is a problem for us. Now we have to find out which drugs is good in OC. I have published one journal, international journal, Sirajet is the only drug which can be used during the lactating mother, because this drug will never harm to the baby. This is the only thing. Secondly, medical abortion that is not allowed with the drugs. Now, if you want to take the drugs, when the mother has a menstrual cycle is normal after the delivery, then you take the drugs. Otherwise, my only concern of the safe motherhood, our mother is not safe in the rural and industrial area because of repeated pregnancy. So we take the awareness program to that mother that should not be any pregnancy after delivery at least for 3 years. So this is, we have published the journal in the IMA journal 3 months before. So thank you very much for excellent presentation, and I hope so our work, our motherhood is safe in India under the leadership of J.A. Joylal sir is excellent. He has created all these problems. We as a gynecologist, but he as a big surgeon thinking of the safe mother. And that is why, on behalf of me, at this age of above 70 years, I salute him, sir. You are thinking something new, and which I like it to my core of my heart. That is the thing, sir. So thank you, Erika. I am always with you. I am always with you till my death. IMA is my core of my heart. Thank you very much.
Thank you so much.
Dr. Jailal sir, sir, would you like to just conclude? Say something, sir.
The choice of subjects, speakers are really excellent. Today, many of the topics that we tend to avoid discussing in the seminars and meetings, and you have very rightly taken up the topics. It was well executed. I am able to see this is a new phenomena is developing. IMA with a lot of youngsters, you from Foxy and a lot of people coming together as a formidable team. I think this unity and this should go forward and do something a palpable change. We should make it. Well done. I am so happy. Keep it up.
Thank you, sir. Thank you so much.
Thank you, sir. On this note, I would like to conclude this meeting. Tomorrow, we take it even more further than this, and tomorrow we talk about the baby and how important it is for even a mother to know all aspects of breastfeeding. There is so much of confusion. There are so many questions that a mother has, and it is so important that we get them ready for postnatal period much before they actually go through it. So tomorrow we will be discussing everything about the baby and how all of it a mother should also know so that it makes it easier for her. So I like to call everyone tomorrow, same time at 8 p.m. Thank you.
Thank you. Thank you so much. Thanks, Dr. Erika.
Thank you, Narmada.
Thank you, ma'am. Thanks a lot, ma'am.
Thank you all. Thank you, Erika. Thank you, Jailal.